Okay, good morning. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thanks for joining us today for our fifth webinar of the Winter SRS webinar series. Held every Thursday between now and May 6th, this series does include 11 talks. So if you haven't already, I encourage everyone to visit srswebinars.com to review not only the upcoming presentations, but also register to view recordings of prior webinars as well. And one item of business before we get started. If you'd like to submit typewritten questions at any time during today's talk, you can do so by using the Q&A button found in the Zoom console. And time permitting, your questions will be addressed at the end of today's presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the Cyberknife robotic radiosurgery system, and Professor Emeritus of Neurosurgery and Radiation Oncology at Stanford University. Dr. Adler, over to you.
Thank you, Mark, and would like to thank everyone for joining us this morning, this evening, wherever you are in the world for our ongoing webinar series. I'm delighted to introduce today's speaker, Ian Paddock. Ian is a physicist who has really defined many of the standards by which radiosurgery is delivered today. He's been one of the leading lights in characterizing, understanding, and driving and innovating even the mere vocabulary by how we judge qualities of treatment that we deliver each and every day. And he's done this for decades now, even though he's still a young man. His work today is going to characterize how good all our different tools are in minimizing radiation to the entire body. And so he's going to be discussing the lifetime risk of the radiosurgery we give each and every day. To show you how much what esteem I hold Ian Paddock, I want you to know that I even named my grandson after him, Ian Yarshwin. So not really, but the name Ian means a lot to me. Ian Paddock means a lot to me. And I think the work that he's done means a lot to me. And Ian is going to start showing us how and why we do great work, but maybe we can do better. So Ian, take it away.
Thank you, John. I'm impressed that you've named your grandson Ian Paddock. That's great.
Well, you got the first name right.
So thanks everyone for joining me today. So I'd like to talk about lifetime risk from extracranial doses received during intracranial SRS. I'm not going to cover malignant transformation or even the induction of tumors in the brain. That becomes extremely complex because we know that depending on what we treat and what device we treat, we're going to give very different doses to the brain, and that will be accompanied by different risks. My disclaimer, I perform ad hoc consultancy work for Elekta. Probably more importantly is that I work with a Gamma knife, and we're all biased towards the devices that we work with. I also work at one of only 2 centres in the UK that are approved for paediatric SRS treatments. We're treating a 7-year-old girl tomorrow for an AVM at that centre. So I want to start with maybe a controversial statement to begin with. Most patients that we treat don't have cancer. So this is a pie chart of treatments by indication from the Lexell Gamma Knife Society for 1.3 million patients. And it shows quite clearly that for Gamma Knife anyway, malignant tumors are a minority, only a slight minority, just under 45%. We then have around 37% of cases which are tumors but benign. But then we have around 18% that patients that don't have any tumors at all, and they're divided between, of course, vascular and functional disorders. So vascular disorders makes up of around 11% of what we treat. And the mean age of AVM patients receiving SRS in the UK is around 35 years. So these are young patients who are expected to live to the same age as their peers. So if we're treating a 35-year-old patient, we would expect them to live for around another 50 years. That's 5 decades in which malignancy or mutations that can be induced in that patient during their radiosurgery can then result in malignancies. So I hope we can all agree that radiation does cause cancer. There are a number of studies which are very, very interesting, demonstrating the link between radiation and cancer. A lot of them are controversial. This one is one that's controversial, but it's interesting because it's looking at 11 million Australians, of which 680,000 people received CT scans in childhood or adolescence. Of this group of 11 million, over 60,000 had cancer diagnosed. 6.2% had a CT scan, and the cancer incidence was 24% greater in the CT scan group. And that risk increased by 16% for each additional CT scan. So the absolute excess was just over 9 per 100,000, but that was at 2007. These, although there are a large number of patients here, there was quite short follow-up. And this is one of the problems with demonstrating a link between radiation and induced cancer, is that you need huge numbers of study subjects, and you need a lot of follow-up. You know, ideally 50, 60, 70 years is what you need. And of course, we don't have that for the vast majority of these studies. How does ionizing radiation cause cancer? We're using it to treat cancer a lot of the time. But if the DNA is damaged by ionizing radiation, you've got 3 options. One is that the DNA is correctly repaired, in which case there's no increased cancer risk. The other option is that the DNA damage is beyond repair, in which case the cell dies, in which case there's no cancer risk because a dead cell can't turn malignant. Or you can have a DNA misrepair or lack of repair. In that case, you have a mutated cell, and that's a stochastic or random effect. So we don't know in what patients that will actually eventually turn out to cause a neoplasm. And is there a safe dose of radiation? Well, this is hotly contested. The generally accepted model is called the linear no threshold model. It's the red line on this dose response curve. So your risk is proportional to the amount of radiation that you receive. But there is the linear threshold model, and that proposes that there is a certain amount of radiation that the body can receive with no additional risk. And then after that, the risk occurs. And that's generally believed to be, of the proponents of this model, around 100 millisieverts, so 0.1 gray. But there's also a hormetic model, radiation hormesis, and this is the idea that radiation, small amounts of radiation, actually do you good. But I don't think that is really seriously taken up by the scientific community. And it actually reminds me, looking at the evidence for it on the internet, it's a little bit like the issue with the anti-vaxxers at the moment. You know, there's lots of talk on the internet, but very little peer-reviewed evidence for that. So to quote Pennington and Siegel, the linear no threshold model of radiogenic cancer is false because it fails empirically against superior empiricism. It becomes misinformation and opinion, not knowledge. But it is still advocated because it lends contentment to believers. And certainly all of the national and international radiation protection bodies believe that there is no threshold dose where radiation is considered to be safe. And the ICRP estimates the risk of developing a neoplasm per unit dose to be around 7% per sievert exposure, where 1 sievert is 1 gray if you're dealing with acute exposure of photons. Now, there's a very interesting study that was published just about 5 years ago, a huge study looking at occupational exposure to nuclear radiation workers. There were over 308,000 nuclear industry workers from the UK, USA, and France, of which almost 18,000 died due to solid tumours. The great thing about this is it's a very large cohort, but those workers that were wearing film badges, you've got a very good idea of what dose they received. There are 8.2 million person years of follow-up. That's a huge study. And it was found in this study that there was a linear increase in risk from death from solid tumours per gray, which included the 0 to 100 milligray range. So that strongly suggests that there isn't a threshold. There was a 48% increase in death from solid tumours per gray. That's significantly higher than the ICRP estimation. And their 90% confidence interval was between 20% and 79%. But the risk per unit of radiation dose for cancer was similar to estimates derived from the studies from Japanese atomic bomb survivors, which is also the other very important group of data that we use to estimate radiation risk. So when we're looking at radiation-induced tumors in the body from intracranial SRS, this is really important because SRS patients are often treated for benign disease and they have a very long life expectancy. It's not like in conventional radiation therapy where really the last thing you're going to worry about is whether the patient develops a tumor 30 years ahead. You know, they've got malignant disease, life-threatening disease, and they need to be treated now. But the dose from SRS, although it's low dose, so we measure it in milligray, it is relatively high volume. In fact, it's the whole body. And it might actually represent the largest risk to the patient. It's very much platform dependent. So it'll depend on the shielding of that platform, the imaging associated with the treatment, and also the beam orientations that are used to irradiate the target. This is work from the Health Protection Agency of the UK, looking at the lifetime risk per million versus age for males and females. And one of the things that I learned in this, the work that I've been doing looking at the risk of SRS is how dramatically the risk varies with age. You can see here that there's basically a linear decrease in risk with age of the patient, but also the huge difference there is between male and female, with females having about twice the risk compared with males. And the reason for that is the risk from developing breast cancer. And you can see here that the female breast is extremely sensitive to radiation. If you compare the risk between a 7-year-old and a 70-year-old, it's a factor of 50 difference. So when we actually look at this in graphical format, you can see there's an exponential rise in the risk from breast cancer as you decrease age. So this is a study that was published online, I think December, and I think it came out in print this month. So hot off the press, this is a a study where we looked at the body dose. We measured that for 20 Gamma knife patients using TLD along the length of their body. And then we compared that data with the doses, body doses from other platforms that were published in the literature. And then we used something called the RadRat model to model the lifetime risk of those patients, varying age and sex. If we look at the table on the bottom right, you can see the quite heterogeneous group of patients that we studied. So we've got meningiomas in there, multiple Mets, vestibular schwannoma, we've got AVMs, and we've also got 2 functional cases for trigeminal neuralgia. And the difference in dose received by patients could vary by as much as a factor of 20. But we must also remember that the volumes irradiated in these patients varied by a factor of 50. And volume has quite an effect on definitely the dose to the upper body, which I will show you later on. So we were looking for good data in the literature on Cyberknife and LINAC treatments as well. So there's a very good paper on Cyberknife treatments by Wrapup. He looked at a series of 21 patients, so very similar to our 20 patients on the Gamma knife, using MOSFET dosimeters along the length of the body. And he performed measurements before and after supplemental shielding to the Cyberknife. But the measurements that we used were after the supplemental shielding, and you can see those at the bottom. So about 0.3 gray, 0.1 gray, just a little bit over 0.1 gray as you move along the length of the body away from the head. For LINAC, there's actually very little data in the literature. The paper that we used in the end was the one by DeBetta. These are doses that were performed on an anthropomorphic phantom. They performed doses for body dose measurements for micro MLC, but also for cones, which was very interesting. But unfortunately, there's no adequate data for FFF treatments. There's a great paper by Jason Cashmore on body doses after conventional radiotherapy, but large volumes were irradiated. It certainly looked as though the doses from FFF treatments are lower, but it would be nice to have that backed up with a paper looking at radiosurgery treatments. So if we plot all of the data together on one graph, we had to use a semi-log plot here when we're plotting mean extracranial dose as a percentage of prescription dose against the distance from the isocenter, because there was such a huge variation depending on which platform you were looking at, not just along the length of the body, but the actual platform used. So you can see at the bottom the line in mauve is for the Perfection Gamma knife, but it would also be applicable to the Icon Gamma knife. And then above that in green is the LINAC with micro MLC. Just above that in blue, the LINAC with cones, and then above that, the Cyberknife. So there's a significant difference between, let's say, Gamma knife, well, and LINAC, maybe a factor of 10 difference, and then a factor of 10 again with Cyberknife. How did Zapex perform? Well, lucky enough, thank you very much to Dalang Pang for providing TLD measurements on a single patient, this is. But you can see that ZAP performs significantly better than LINAC and Cyberknife, and it's just a little bit higher than the Gamma knife. So that's the yellow line you can see on this chart. Now, if we're considering the risk to pediatric patients, we've got what I call a double whammy effect, because younger patients are shorter. And if you're a shorter patient, all your organs at risk are going to be closer to the isocenter than those for a comparable adult. And this can make a significant difference. So a small child can have doses that are 5 times that of an adult because their organs at risk are closer to the isocenter than a comparable adult. So you can see that here. I've just plotted the extracranial doses for Gamma Knife here, but you can see that basically the taller the patient, the further their organs are away from the isocenter, the lower the dose is that's delivered. So we could have just looked at these doses and said, well, what's the rough body dose for this? Now, clearly there's quite a gradient along the length of the body, so that's sort of incorrect. But in this very early work that we did, this is a very old slide, we said, well, maybe the mean dose to the body, we can say it's the equivalent dose that's received at 40 centimeters inferior to the target that's being treated. And if you use the ICRP data, which is around 7% per sievert exposure, you get extremely low lifetime risks. But actually, we need to drill down deeper than that. And there is, on the NIH website, there's a fantastic tool called RadRat, which is a radiation risk assessment tool for lifetime cancer risk projection. This allows you to enter in the dose received by each individual organ in the body for a particular population of patients, a particular age and sex, and calculate the overall risk. So we performed this for an English population exposed in 2017. And then we calculated that for males and females aged 5, 15, 25, 35, and 45 years at the time of exposure. And those that were aged 15 and upwards were assumed to be adult size, but for the 5-year-old patients, the doses were rescaled to account for the organs being closer to the isocenter. And these are the results that we received from RadRat. So if we look at the top left, these are the lifetime estimated risks versus age for Gamma Knife perfection treatments, but also applicable for the ICON. So you can see the maximum lifetime estimated risk is somewhere around 0.9%. That would be for a 5-year-old female receiving 25 gray to an AVM. So that's a really extreme example. That's really about the highest risk patient you can think about. But you can see a significant difference depending on whether the patient's a male or female. And we've modeled the dose for a 12.5 gray prescription dose, which is maybe typical of a benign target, and 25 gray, which is what we think might be typical of an AVM treatment. If we look at, on the right, if we look at LINAC with micro MLC, you can see fairly low doses in terms of a few percent, but they can approach 10% for these very, very young patients treated with a very high dose. The same with the LINAC treatments with cones. And then quite controversially for the Cyberknife, we can see very, very large doses. If you're a male that's 45 years of age, then you have a very, very low dose. But if we're looking for these particular pediatric cases, particularly the females, the dose can be extremely high. And really, these results that we got really needed checking and double checking because they appeared to be incredibly high. So what can we do to reduce the radiation dose to the body and hopefully reduce the overall lifetime risk of our patients? Well, the dose actually comes in is delivered in 3 different ways. So first of all, we get scatter from the treatment head itself. Now that's platform dependent, so it depends on the shielding and design of the collimators, but it also depends on the number of monitor units, and that of course depends on plan complexity. And I wonder sometimes if we're treating a young pediatric patient and we're really trying to push the treatment plan to the nth degree, we're trying to make it as conformal as possible to reduce the risk of symptomatic radiation necrosis. If that results in a 20–30% increase in the number of monitor units, we might actually be doing the patient a disservice because we're increasing their lifetime risk with negligible improvement in overall plan conformity. Secondly, we have scatter within the body. That's dependent on the volume that we end up treating and the integral dose to the head. Now, although we can't affect the volume that we need to treat, we can try and maximize the dose gradients outside the target. That will reduce the integral dose, and that will reduce the extraneous dose in the body. This scatter within the body tends to just affect the upper half of the body, as it doesn't penetrate too far, maybe 30 centimeters. So I mentioned earlier for the gamma knife, extracranial doses varied by a factor of about 20, but the volumes irradiated in our cohort varied by about a factor of 50. And so that factor of 20 is partly explained by the different volumes irradiated. And then thirdly, you've got direct irradiation with the primary beam. And this very much depends on planning technique. It's not possible to deliver with the gamma knife or the ZapX. It is possible to deliver these treatments with a conventional Linac and a Cyberknife. There are some Cyberknife groups that deliberately block beams going in this direction through the apex of the head and down through the neck, and you can block beams, but there are a number of centers that don't do that. So Vlachopoulou's data was from a center where they didn't block beams, but DeBetter's data for Cyberknife, which shows lower extracranial doses, is partly as a result because they did block beams going through the apex of the head. And you can see here a number of different images and different irradiation techniques. And you can see here which ones are going to deliver primary beam down the length of the body and which ones are going to be much safer for the patient. Another thing that we recommended in our paper was something called a therapeutic reference level, but we'll start with what is established, which is a DRL. That's a diagnostic reference level, and it's a specified radiation dose which is not expected to be exceeded for a particular diagnostic examination. It's like a benchmark dose, if you like. And you can see on the right, this is the latest DRLs for published by Public Health England for different CT examinations. So we can see here, for instance, a CT of the chest for lung cancer should have a CTDI of around 12 milligray. And this has been extremely useful for diagnostic departments because if you've got an old antiquated CT scanner that you think is giving a much higher dose to your patients than a modern day one, sometimes it can be very difficult to make a business case or a justification for replacing it. But if you can demonstrate that actually it delivers doses which are higher than the national diagnostic reference levels, then that's a very good excuse for replacing the scanner. And a therapy reference level could work in the same way because implementation of DRLs have resulted in significant reductions of the dose per diagnostic procedure. And it might be that we could use TRLs in a similar way and start to benchmark some of the doses that are delivered. So our paper concluded by saying that these lifetime risks vary dramatically depending on the age and sex of the patient, the radiosurgery platform used, and therefore should be considered when offering treatment. One of the advantages of performing this work is we felt fairly confident when we were brought a patient that was 31 weeks pregnant with a cavernous sinus meningioma with increasing cranial nerve deficit. The neurosurgeon didn't want to delay treating the patient. Using our data, we were able to model and estimate a 2 millisievert dose to the abdomen. Just to be sure, we placed electronic dose meters to the upper and lower abdomen during treatment. And the results that we got were quite similar, but a bit lower than the estimated dose. So we got a mean dose of just under 1 millisievert for this treatment. And if you compare that with, there's a case report by Pantelis et al. For the Cyberknife, which showed a mean dose of 42 millisieverts for a similar radiosurgery treatment. Now, putting this this presentation together actually reminded me of my very first paper that I was involved with, which was exactly 25 years ago. And there are a lot of parallels between that and the work that I've just shown you, because in this study, we were looking at how we could reduce the dose to the contralateral breast during breast irradiation. Now, we know that certainly in 1996, a lot of breast radiotherapy patients didn't actually have cancer. We were irradiating the breast after surgical removal, and we knew that a number of these patients wouldn't relapse if we irradiated them. So just in the same way that a lot of our SRS patients don't have cancer, this was the case here. And we found that we were able to reduce doses to the contralateral breast by 46% with simple plan adaptation and bolus. So I thought I'd just show you that. So to summarize, lifetime risk has been calculated to be in the range of 0.1% to 39% using the RadRat tool. The lifetime risk varies dramatically with age and sex. Pediatric patients are shorter, so the organs at risk are closer to the isocenter. So the principle of ALARA, that's as low as reasonably achievable, should be applied to these young non-cancer patients. And there's a wide range of body dose according to the platform used. I'd like to thank my co-authors, Alexis Dimitriadis and Alison Cameron. And last slide is just plugging a session that we're giving on technology and radiosurgery this coming Saturday from the ISRS. And I'll be talking about Gamma Knife, but Stephen Sorensen will be talking about ZapX. So thank you very much for your attention.
Thank you, Ian. As always, enjoyed your talk very much. I'm going to invite the audience to pose some questions if they have any. And when they start, I'll pose those questions too, but I'm going to start with my own. I'd like to start with my own observation and somewhat of a philosophical thing. And so I feel that the entire topic of the risk of radiation has been polluted by the inclusion of children into many of these studies. Not that children aren't extremely important, but I think that the risk in children is so disproportionately higher compared to adults. And you really need to stratify the entire discussion, as far as I'm concerned, between children and non-children. And that's kind of a philosophical statement, but would appreciate your response to what I just said.
I completely agree, John. There's a huge difference. And it was something that I didn't really appreciate until performing this study, the large difference that there is according to age. But, it's not just children. If you're a 25-year-old, 35-year-old, your risks of developing a secondary cancer are, many times more than a 70-year-old patient. And certainly none of this talk was directed towards treatments of either malignant disease or patients that were, let's say, 60 plus, because they're far less likely to develop mutations, and they're far less likely to live long enough for those mutations to result in a secondary cancer.
Sure. I want other people to start asking questions before I, get on my lecture podium here and talk more. So, okay. So, given the prominence in treating pediatric patients, do you have an idea of how protons would look in regards to extracranial dose? Great question. A proton.
Yeah. Well, we mentioned that a little bit in our paper because one of the advantages in protons is supposedly the lower dose to pediatrics, but here we're talking about the doses that are way outside of the primary beam. So I think I just recall one paper on protons which showed that there wasn't a huge difference between the two. I don't think it will be that much lower, but we don't actually have any real clear data in the literature. Otherwise, we would have included protons in this study.
That's surprising because the primary raison d'etre for protons really is the treatment of children. I mean, the only place where it seems to have a unmistakable potential advantage, I thought, was in minimizing scatter to small kids. So I'm shocked that what you're telling me. Next question. With regard to the Cyberknife model data, which type of Cyberknife model and collimator system was used? Do you know? Are you aware?
I can't recall offhand. So the Wrapup data was published in 2011, and they talked about a pre and post shielding upgrade. So we're probably talking about a fairly antiquated Cyberknife.
Okay. Well, someone then needs to sort of update that study.
Absolutely. Yeah.
Right,
we
Alex?
need to have more studies in this area.
Gotcha. Here's a good question, something that I was going to ask about. Have any protective screens been tried or tested to reduce scattering to the body? And I was thinking specifically myself with regard to the breast.
Yeah. The problem is that a lot of this radiation is still MV, so it's very high energy, and you need a huge amount of shielding to lower the dose. If you put a small amount of shielding on, it can actually end up being used as build-up, and actually you can end up increasing the dose to certain organs. So you have to be very careful about that. So my understanding is that very little work has been done in this area. I have seen a contraption designed by one center where they used this huge sort of like trolley that they wheeled over a patient. I think it was a pregnant patient with, but this thing weighed, half a ton or something, with significant amounts of lead to reduce the dose to the fetus. So no, it's not very practical to do, unfortunately.
That makes sense. So here's a comment here. The current Cyberknife with like the M6 and S7, I'm not sure what those numbers are much more MU efficient than the old G4 used in the cited study. So, okay. So I guess the argument here is that newer versions of the Cyberknife would do much better than the study from 2011. Since cancer risk increases with MU, the graphs presented do not represent the current state of Cyberknife technology. So it seems to me this requires a new publication by the Cyberknife community, and I've got the perfect journal for them. So I invite you to do that. So the risk can vary with diagnostic imaging and radiosurgery, but does your team account for a combination of both to assess the risk in your model? So to what extent does diagnostic imaging contribute to the overall risk here in radiosurgery?
We address that in the paper, but it's extremely difficult because, well, if we're talking about diagnostic imaging, that varies depending on department policy. So, there are some Gamma Knife centers where there's no diagnostic imaging in terms of no CT diagnostic imaging. Everything's done on MRI. And then in terms of treatment verification, localizing images, that's something, again, which is really specific to the individual department. So it was very difficult to quantify. So we actually ignored imaging from this study completely.
Okay.
But it tends to be that imaging, or it's fairly low dose, but it tends to be to the area that you're treating. So yeah, you get a reasonable dose to the head, but a much, much lower dose to the body. So I don't think it would make any difference to the findings.
Okay. Then they ask about the Gamma Knife. They want to know where the scatter, I am trying to interpret this question, is the radiation to the patient body come from radiation leakage through the head? Or is it really just, I believe that's the question, or is it just scatter off the head and the primary target?
Yeah.
Is there any leakage from the Gamma Knife, I guess, Gamma Knife sources?
Yeah, well, the Gamma Knife has about effectively 18 tons of shielding. So you get very little radiation leakage through what we'd call the head or the radiation unit. So I think a lot of the dose from Gamma Knife is actual internal scatter within the patient, but that's extremely difficult to measure and quantify. It would be a great study to do.
Okay, I can answer this next question. It was in the ZAP-X, are there beams that go down the long axis of the body and contribute to whole body scatter? And the answer is no, there are no beams that go down the entire axis of the body that would result in the disconcerting scatter radiation that Ian was showing, particularly in that example of a pregnant patient. Question, this is a Cyberknife, another Cyberknife question. How about the risk of image guidance used in the Cyberknife with KV images? Separate that from the actual treatment end of the Cyberknife. Any comment there?
Yeah, I think going back to my previous answer regarding imaging, it really depends on departmental policy as to how often you're going to image the patient. But my understanding is that if you're using a lot of KV images on Cyberknife, they're going to be directed towards the area that you're treating. That's got a high dose anyway, quite rightly, because that's the area you're delivering dose to. And so the body dose from an intracranial treatment, I don't think the dose from imaging will be that high.
Gotcha. The next is an interesting comment. It said that the larger incidence of breast cancers in females due to CT is related to the larger breast volume in women, which therefore DNA repair can go wrong. So there's not necessarily per unit, let's say per cubic centimeter of breast tissue, there's not necessarily a difference between men and women. Any care to comment? I mean, I think the logic there is pretty straightforward, but your thoughts?
Well, surely if that was the case, then irradiating a 5-year-old male and a 5-year-old female, there would be an equal risk because breast volume would be the same in both those patients, but clearly there's not.
So, okay, so I didn't see that in your data, but if you look specifically at breast cancer, you notice that there is this differential still in that situation that you just described.
Very much, yeah.
Okay, well, it could be hormonal. The fact is that so much of breast cancer incidence is about detection, not necessarily the incidence, the true incidence, and some of that is certainly modulated through hormones and also screening. Who knows? Maybe there's a lot more breast cancer in men that's just never been picked up. It probably is true. But anyway, it's still an interesting point on both sides of the discussion. What is the relative contribution of developing secondary brain tumors to the overall excess risk? And this is the Sheffield data. Would you talk more about that?
Absolutely. So yeah, Jeremy Rowe's study where with the Sheffield cohort, they were able to look at, I think, 50,000 patient years of follow-up, which sounds really impressive. And in those 50,000 patient years, they found no difference between the general population and the population that had been treated with their gamma knife. And that was a very old gamma knife, actually. So, the radiation protection in that might not have been as good as with the modern day gamma knives. However, 50,000 patient years seems like a lot, but actually, when you compare it with the 8.2 million patient years or person years of follow-up in the nuclear workers study, it is actually quite tiny. And unfortunately for these studies, we need to have huge populations to be able to really detect whether there is an additional risk. But certainly it was reassuring to see that with 50,000 patient years, there was no excess risk. The brain is a relatively resistant organ when it comes to developing solid tumors. It's quite radio-resistant in terms of mutations.
Well, meningiomas are quite prevalent in post-irradiated people, however. Especially young people who got radiated for tonsils, for example, had a very high incidence of meningioma recurrence. Again, young being the operant word. Someone asked about the whole body exposure of the Zap-X relative to the Cyberknife, relative to the gamma knife. And as you point out, Ian, the Zap-X seems to approximate what's possible with the gamma knife so far, and perhaps we'll do better in the future. To what extent does 3MV or the cobalt energy versus the 6MV account for some of the differences in whole body radiation dose?
That's a good point. Well, for the same amount of shielding, you're going to do much better at protecting the patient if you've got a 3MV beam as opposed to a 6MV beam. So that would be the first point. The radiation, the internal scatter within the body is going to be a bit less, so that will help you as well. So I think it would be quite a positive thing to have a 3MV beam compared with a 6MV beam. And we know that gradients outside the target tend to be better with lower beam energies as well.
Well, I'm going to ask the last question and make as much of a rhetorical statement as anything else. And since I'm the moderator, I have that luxury. So I was heavily influenced myself in my thinking about this a few years back when I was at a dinner attended in China, in Shanghai, was hosted by the Chinese Institute of Radiation Protection, but I was also joined there by a number of kind of radiobiological experts from Oak Ridge National Labs. And we talked about, hormesis and the whole idea of there being a linear no threshold model. Was that the right way to think about radiation? And they were adamant that it's entirely a political construct, is that all these people have been trying to spend their careers trying to demonstrate that there is minimal injury from low dose radiation, this threshold level, but it's just politically an untenable notion this day and age. So it fuels some of my skepticism, albeit accepting children. I think children, as I said, are a unique, are unique creatures. And I think it's undeniable that there is radiation injury consequences, primarily cancer, in young children. But my reasoning for older, for there being such a threshold dose, is that we know that humans go through their existence with getting radiated. I mean, being radiated is part of humanity, part of being alive, whether it be cosmic radiation or just other natural sources of radiation. In fact, we have DNA repair mechanisms to kind of address that. And so just from an anthropological reasoning standpoint, it stands to reason that we can tolerate a certain threshold dose of radiation. Now, that is not as elegant as some of the statistical studies you showed from badged nuclear energy workers and things like that, but there too, you don't know that even the badged dose may just be a marker for other sort of behaviors. Since, if you're getting more radiation in the first place, maybe you're kind of somewhat of a reckless person to start with. So anyway, that's my question. Is there an anthropologic reason to think, heck, a little bit of radiation is good? And we know from historically that generations past, people went to sit in radiation baths because they thought a little bit of radiation was good. So that's a rhetorical statement, and just like your response, given my own prejudices here.
Thanks, John. Yeah, I agree. It's
We're speechless.
very, yeah, very, very difficult to do. The only thing that I would argue is if definitely in the case of a child, if a child receives 200 millisieverts from an SRS treatment for their AVM, that's more than the radiation that they're going to receive from background for the rest of their life. Because the dose.
No question. Children, no question. No question with children. No question. But how about adults?
Well, adults still, if you're getting a dose of 0.1, 0.2 gray acutely during an SRS treatment, that is still a lot more than you would experience in any other sort of naturally occurring scenario. So,
yep.
Yeah.
Okay, well, again, a brilliant talk, Ian. And thank you for your great work in this area, and I hope you keep it up. And those in the audience who felt that perhaps the Cyberknife got a bad rap here, I hope you can redo some of your own work in this field and show that things are improving. And I think perhaps with more thought by all of us, we can deliver less and less radiation to our patients and ameliorate some of the potential risks that Ian's talked about today. So thank you for joining us, and everyone have a great day. See you next week. Bye-bye. Thanks, Ian.
Goodbye. Thank you.
Bye.